You're listening to My Favorite Show, where Dr. Richard Call and Greg Riccardi discuss the matters that matter most. Join the conversation by calling 800-962-1160. And now, Dr. Call and Greg Riccardi of My Favorite Show.
All right, Greg Riccardi here with My Favorite Show, sitting next to my co-host, Dr. Richard Call. How you doing, Doctor?
I'm doing well, Greg. Good evening, folks.
Fantastic. Well, we have a couple of housekeeping notes that we're going to go through before we start. First of all, we have a website associated with this show that we're very proud of. It's MyFavoriteShow.com. We encourage you to go there. We're actually videotaping this session here tonight, as we have with previous sessions. We'd love for you to check out the videos there. And also want to let you know this is a very interactive program. We'd like you to please call or text in your questions. Call 800-962-1160 to ask your question via phone, or you can text us at 313131. Text MFS for My Favorite Show, then put your name in there, as long as the question, along with the question, I should say, and we'll try to get it on the air. How's that sound?
That sounds great. And as always, no excuses. Send your questions in by email, text, or voice.
There you go. So, want to, now for our listeners' sake, I mean, many of them know your background, my background. Just to kind of reiterate that you are, your specialty is in interventional pain and minimally invasive spinal intervention, correct?
Correct.
That was a mouthful. My background is marketing and video production, actually, for many years. And perhaps it's because of your doctorship that we've got a lot of emails this week and inquiries about back pain, about neck pain, and and separately about marketing your business and stuff like that. But I think we got more about the back and neck, right?
Yeah. I would definitely say that 70% of those inquiries were about people's neck and back problems, which doesn't surprise me, because 85% of the population in the United States at some point in their life are going to experience symptoms in their cervical neck or their lower back. So it's actually the second most frequent reason that people go and see their doctors after the common cold.
Really? Wow. I'm definitely in that category as far as back pain. I've had it, I've had it before. There was one time I have to say that I woke up and my neck was, like
twisted to one side,
and I couldn't move it. It kind of went away on its own, but
it's called a locked neck.
Okay.
Yeah.
Locked neck.
Yeah.
Is that like locked neck monster or something? No. What is that?
Well, what happens when you sleep in an awkward position with cheap pillows is that
oh man,
is that the these little joints, they're called the facet joints. They slip and they get locked.
Right.
So when you wake up, you feel as if you're kind of stuck in that position, and it takes a few days for it to loosen up, and you get some spasm, and it eventually settles down.
Is that how your voice got stuck that way?
That's right.
Okay. Okay, so why don't we talk about that this show? We wanted to invite our callers, if you have or have ever had back pain or know someone who has, please give us a call and ask your questions of the doctor. But we wanted to start off, I think, with some definitions of certain ailments that
right.
Are
So
prevalent.
yeah. I mean, medicine has a language all of itself. So there's a lot of terminology that patients will often ask, what does that mean? That's one of the reasons why we've brought an expert, Dr. Victor Katz, onto the show tonight to help us. Yes, really.
We have a guest today?
We do.
That's fantastic. I'm shocked.
Well, we could have an empty chair, just like at the Republican convention.
Right, there you go. Okay. So now, before we get into, some of the ailments that there are and, some of the things that people might be experiencing, the treatment of back pain over the past, 10 years, 5-10 years has radically changed.
Yeah,
right?
yeah. I mean, it's undergone a renaissance, and I'm going to let Dr. Katz actually explain that. I mean, I could go on about that for weeks, but we've got Dr. Victor Katz here, and Dr. Katz, before we get into that, I'd like to just ask you to tell the listeners a little bit about yourself, your training, your education, how you came to become an expert.
Sure, that's a good question. I am board certified trained orthopedic spine surgeon. I did my training in orthopedics in Catholic Medical Systems in Brooklyn and Queens, and then I went on to do a spine fellowship in California at Seton Medical Center. After that, I came back to New York, and I worked in a group first for a couple of years, and then I went on and opened my own practice.
So that's a long period of education and training. I mean, it really starts, from the time you commence college and then have to go to medical school and then residency.
Sure, it's a long time since, because after high school you do usually 4 years of college, 4 years of medical school. I went to a 7-year medical program, so it was a combined program where I did the 4 years of college and first 2 years of medical school in 7 years, and then I completed my medical education at Stony Brook, where I did all my clinical rotations.
Right.
So, and then after that, you do basically a internship in general surgery, and then another 4 years of orthopedic training.
But let me ask you a question. Sorry to interrupt you. Being a physician myself, I get asked this question often about medicine and what it was that inspired or made me choose medicine. And in my case, it wasn't really me; it was chosen for me. But I'm going to ask you that question. What was it specifically?
Well, that's actually a great question. My mother was a pediatric orthopedic surgeon in the Soviet Union, in actually Ukraine, Odessa. At one point, she was director of the department in a facility which specialized in treating. We're talking about like 50s and 60s.
Right.
In Russia, in Ukraine, there was a big polio epidemic where lots of kids, when they reach teenage years...
And polio being the virus that affects the spine?
Well, yes, it affects the spine, and kids develop primarily motor deficits. They get foot drop, it affects sometimes one, sometimes both extremities, and they have difficulty with function. They have difficulty with walking,
right.
And because of the progressive deformity of their feet, and sometimes arms. So in that facility, my mom... First, she became a pediatrician, and then she basically wanted to respecialize and became did more training and became an orthopedic surgeon, where her primary goal was to restore function by transposing muscle groups and reestablish proper position of mostly in the feet.
In the feet. So all the patients today that you've helped have your mother to thank for that, right?
Correct. She inspired me to basically become a doctor and to pursue a career in orthopedics.
It's like he grew up in the business.
Yeah. No, well, that's and then after having had that inspiration, you then decided and went off to college and went through college and then went into medical school.
Well, I kind of decided to become a doctor early while I was still in high school. I was a volunteer in Clinic Hospital in Brooklyn, where I lived, and then while in high school, I decided I wanted to pursue a career in medicine, and I applied out of high school into a 7-year medical program at City College.
Right. So to any of the younger viewers, and I'm assuming listeners. We do have some younger listeners
and viewers on the video on the website.
Well, that's right. Some of the ones under the age of 18, if there are any, thinking about a career in medicine. I mean, it's a long road. Right? I mean, it takes a lot of...
It's a long road. It's something that you literally have to dedicate your whole life to, because it's not a short-term, like quick, easy way to make money, or it's something you have to dedicate your whole life to, and it's a career, and and it's something that I think once you reach a certain goal, it's something that becomes very fulfilling,
right?
Both emotionally and psychologically and so forth.
So it's like the priesthood, the vocation.
Sort of, yeah.
How early on did you know that you wanted to go into?
I actually wasn't sure I wanted to go into medicine until high school.
Uh-huh.
I had various
that's
interests.
Early.
in mathematics and physics, and but I finally decided when I was in high school. After doing a volunteer work at the hospital.
Excellent. So how would you characterize your specialty now?
Well, I'm 70% of my practice is spine surgery, and I do the full gamut of spine. I do from minimally invasive, which is a particular interest of mine, but I also do the standard open back and neck surgery for various problems, including herniated discs, for instability, for stenosis, which are all various different problems that involve the spine.
What do you mean by stenosis?
Stenosis is, I guess, a medical word describing narrowing of the canal, which can cause a nerve root compression or central compression. This usually occurs in elderly and has symptoms that typically characterize the patient who can't walk a certain distance. Typically, the patient will come to you and say, I can walk 2 blocks, and then I have this heaviness and this feeling in both my legs, and it feels like I can't continue. I have to stop and sit down. And sitting down usually relieves this pain, and the patient can then continue to walk another 2 blocks. And what's interesting is the same patient will tell you that, but if I was using a shopping cart or a walker, I can walk 5, 10 blocks. And the reason for that is that when you're leaning forward on something, the back goes into a relative forward flex position. So the spine is opening up. Correct. You open up the canal, and then you take the pressure off the nerves, and people can walk much longer distances. So that's a typical sign of spinal cord stenosis, or what we call neurogenic claudication, which is another word to describe narrowing in the canal caused by upright position. Let me ask you a question. Why do you think it is that doctors like to talk in this language that no one else understands? Well, I don't think we like to talk about it. I think that it's a universal language that's universal in the whole world. I mean, if you go to different countries, if you go to England or France or Russia, all of medical language is actually Latin, and some of it is Greek. So it's the same words can be used by physicians from all over the world, and they'll understand what each one is talking about. Right.
All right, awesome. Great to meet you, Doctor. We're going to take a quick break. We remind you to call in with your questions, 1-800-962-1160. You're listening to My Favorite Show, and we'll see you in a few minutes.
You're listening to My Favorite Show. Join the conversation by calling 800-962-1160. Stay tuned for more of Dr. Call and Greg Riccardi. We'll be right back after these messages.
Tornadoes, floods, blizzards, wildfires. Natural disasters seem to make the news every day, and so do the people who protect our communities when disaster strikes. These are the men and women of the National Guard. The proud citizen soldiers of the National Guard are prepared to respond to any situation at a moment's notice. They are expertly trained and equipped to handle the worst nature can dish out, from rescue missions to providing medical care, food, water, and shelter, to restoring hope. The Guard does it all. Maybe you hear the call to serve your community. If so, visit 1-800-GO-GUARD.com. Learn about the many benefits, like programs that can help you pay for college and opportunities to learn career skills. You might even be eligible to receive a bonus. It's time to set yourself apart. Stand out, make a difference. Become a citizen soldier in the National Guard. Visit 1-800-GO-GUARD.com or call 1-800-GO-GUARD now for your community, your country, your future.
Take a look under your bed. Find stuff under there? What about jobs? No? Now try your basement. There's a pair of overalls that overall you're not so into anymore. A perfectly good laptop that hasn't seen your lap in months. And even more stuff. But still no jobs? Well, you really have both. See, stuff is defined as household articles considered as a group. Sometimes this stuff is no longer needed. Wait, no longer needed? That can't be right. Because remember those jobs you were looking for? Those are really needed. And they're the stuff inside your stuff. Even inside that winter coat that moved with you to Phoenix. Our job is to unlock those jobs. And it starts when you donate your stuff to your local Goodwill. Here's how we do it. When you donate to Goodwill, we sell your stuff to provide job training for people right here in your community. So just by teaming up with Goodwill, you help create jobs. And isn't that worth parting with the leftover keytar from your 80s cover band? Goodwill. Donate stuff, create jobs. Find your nearest donation center at goodwill.org. A message from Goodwill and the Ad Council.
Right, here we are back with My Favorite Show. Greg Riccardi, Dr. Richard Call, here with Dr. Victor Katz from New York, right? Okay, great. Awesome. While we were on break, we got an email in from a Jackie. Jackie from Englewood writes in, I just got diagnosed with a herniated disc and it hurts like blank. I can't say what she said, but what are my options? It's all you, Doc.
Basically, that's a herniated disc has many different variations.
Okay.
So I'd have to literally look at the films before I can tell you what she would need. But as a general rule, initial treatment is always conservative. You try therapy, you try maybe chiropractic treatments, maybe some acupuncture, whatever works basically. If after 3 months you still have back pain, again, it's also important to know if they have back pain and leg pain. That will put you in a slightly different category in terms of what you would need to do right away. You may want to get an MRI earlier if the patient is also having leg symptoms, either weakness, numbness, burning in the leg, because that would indicate to me that she is having some nerve root compression, and that could be a much more ominous sign, may require an earlier intervention as opposed to just back pain, which 90% of the time will go away on its own with conservative management.
Gotcha.
So back pain alone is really not something to worry about. It's something most of the time will go away with conservative management. Back and leg pain is something that's more of concern. You want to get an MRI maybe earlier and then take a look at it. And disc herniations are classified anything from a disc bulge, then there's a disc protrusion, which is an asymmetrical outpouching of the disc, which may be either to one side or the other side, more likely to be causing some nerve root compression, or an extrusion. Extruded disc is when the disc has 2 parts. It has an outer annular fibrosis, which is a very tough layer of the disc that kind of holds
the protection.
It's basically like a containment bag. And then you have a nuclear pulposus, which is a soft gelatinous type of
Greg,
material.
I brought actually, this is the spine of an old patient of mine.
Okay, now people at home,
it's
they can't see this. We actually have a spine. You have to go to the website to actually watch the video.
I'm going to hand
We
the
have a
spine
spine
over
here.
to. I've named the spine Fred, so I'm going to hand Fred to Dr. Katz.
All right.
Well, like I said, the disc has 2 main components. The outer layer, which is a tough fibrous tissue, that's a containment bag. And then there's an inner soft gelatinous tissue, which is the cushion.
Right.
So the disc is really a cushioning between the 2 vertebrae, allowing
Shock absorber.
Allowing 6 different ways it can move. It can twist, it can bend, it can shock, it can go up and down. So when the annulus tears or fails, some of this material will leak out or kind of go in outside the confines of the annulus, and that's called an extruded disc.
Okay.
And when that piece separates completely and goes into the canal, that's called a sequestered disc. So it really depends on what the patient's symptoms are, and what the MRI looks like, whether or not you would just hold and treat him conservatively, or you would consider something more.
Right now, actually, we have 2 back specialists here and spine specialists. You mentioned chiropractic, and one thing that I've always kind of felt or maybe assumed or just believed is that chiropractic and traditional medicine are not. I mean, are they diametrically opposed? Are they? I didn't expect you to bring up chiropractic. Is that?
It's a good question. Ask me. I don't think there is a diametric opposition between medicine and chiropractic. Again,
or philosophy difference or something?
I think chiropractic treatments work for certain conditions. In fact, I think there are conditions that deal with primarily pain management. I think that chiropractic may work especially for treatment of SI joint problems and sometimes facet joint problems. Again, I'm not a chiropractor. I did not train in manipulation, but I know that some people go to chiropractors and they feel much better.
Right.
Again, I would not necessarily send somebody to a chiropractor who has an extruded disc with compression
Sure.
of a nerve. I think that falls more in the realm of a medical treatment.
Yeah.
No, I can, Dr. Katz, I can speak here from personal experience because, as we discussed earlier, I've experienced neck pain and I've got a couple of herniated discs in my neck. And when I had those problems, I got myself onto a decompression table to stretch my spine because I think a lot of the symptoms come from a collapsing of the spine, correct? And that causes a compression.
That is correct. However, any stretching you would do on a decompression table would, in my mind, be temporary. It would work great for the next day or two, but once you stand up and you walk around, that effect may be wearing off over the next few days.
Right, temporary.
So yes, I think, like I said, there is a role, I think, for chiropractic. I think, but I don't think it can be used for every single condition that affects the spine. And in some conditions, the surgical treatment may be the best treatment.
But let me ask you, whenever you mention back surgery, when people used to mention back surgery to patients, they would go white shade. It scares a lot of people. But over the last few years, there's been a lot of new technologies that have come into the physician's toolbox, right? That make it a lot safer and supposedly more effective.
Yes, but with the development of new technologies, especially in spine, in fact, the growth of new technology is so fast. Sometimes we need time to reevaluate it to see which of those technologies are going to pan out and do well, and which ones are not. I'll give you an example. About I think 5-6 years ago, an artificial disc came out called Charité. And at that time, every I would say 70% of surgeons were literally flown to a teaching institution where they were taught how to put a Charité disc in.
Right.
And it seemed to be the next best thing since the development of I don't know, since sweet cheese basically.
Right.
And the reason for it is because the premise of it was it was going to preserve motion. And it would prevent a lot of the problems that people developed after fusion surgery. Fusion surgery is when you basically decompress and you bind one or two segments of spine together, which theoretically could lead to breakdown of adjacent levels, or levels above or below the fusion. So once this came out, a lot of people started putting those discs in, the artificial Charité discs. However, we found that with introduction of this new technology, there was also a lot of new complications that were we didn't really see with old techniques, which were the decompression and fusion. One of them was that because it was an anterior approach.
When you say anterior, you mean from the
front?
So coming through the belly or the stomach?
From the belly, right. The Charité disc is, I should define the term. It's not used for the neck. It's used for the lumbar spine,
which is the lower back.
Lower back. And the approach is used to place this disc was through the front.
Right.
And what we found is that once you put one in, first of all, there was more risk of either nicking major vessels.
Right.
There was increased risk of developing blood clots, again because of the exposure. And then if you had to go back in, if you had to revise it, let's say if the disc loosened and came out, it would be much more difficult to do that because of all the scar tissue and also all the vital structures which were right there.
So overall, it was a procedure that entailed a significantly greater degree of risk.
Correct. And what was interesting is this disc was developed in Germany, and when the doctor who developed it, he decided to look at his results 10 years down the road.
Right.
And he did, I forget how many cases, maybe around 100 cases. And what he did was he asked the patients to come back for an interview. He also had an X-ray done, and he asked the patients literally, "How are you doing? Are you doing, excellent, good, fair, poor?" And he asked to rate them in terms of pain. how much pain they were having. So what he found is that the overall results of good to excellent result were approximately 65 to 70%, which were lower than the standard results of doing a decompression and fusion in our literature.
So what you're saying is the way that he collected his data was a little bit flawed.
Well, no, that's not what I'm saying. At the same time, when he asked them to come in, he would also get an X-ray of everybody's back that he put the disc in. And guess what? The people who did good to excellent actually fused. So the Charité disc, which was designed to preserve motion, did none of that.
It was a fusion device.
It was another fusion device. And the ones who did the best were the ones who fused. So this is how I always take it with a grain of salt. Anytime you see a new device that comes out on market, it's interesting to see what will happen in 2 years, 5 years, in 10 years down the road before we sort of jump on a bandwagon and start putting those devices in or start using them.
But do you think that...
So wait, let me just finish my thought. Based on that data, the American government and Medicare stopped paying for this disc, which shortly after led to most insurance companies not paying for this disc, which I agree with. I think it's not a good device because of this data that came out 10 years after it was first developed.
Yeah.
Oh, we have a caller. His name is Key. Key, your question.
Yes, good evening, Greg. Good evening, Dr. Cole. How are you tonight?
Good evening.
Good,
Keith.
good. How are you?
Very well.
Good. And a big caveat to Dr. Katz.
Yes, hi.
Hi. And since I understand you're from Ukraine, I tried to get this out last week, but I guess it's the wrong time. But I have a particular question about...
Mr. Politics.
Oh, boy. Go ahead.
Are you ready, Greg?
We're ready, baby. Go
ready
ahead.
for this one?
Go for it.
Okay. Lack of U.S. involvement in trying to back the stability in Ukraine. It's they're outside the NATO country reach, but it seems like the U.S. is doing nothing to help a country that they talked into surrendering their nuclear weapons to back in 1994.
Now, that's a question directed to Dr. Katz because of his Ukrainian background and love of politics.
I hope so.
You got about 30 seconds, Doc. Go ahead.
All right. Basically, I came into America when I was 10, so I'm more American than Ukrainian or from Ukraine. I think what's happening there is terrible. I think it's a war that's really has its roots based in politics. I think there are many reasons which we have no idea why they're fighting, and that I personally don't think that America should get involved in anything more than political pressure, sanctions, what we are doing. I absolutely do not think we should bring troops to Ukraine and start fighting a war against Russia. I mean, that would be crazy. So I think what the president is doing is actually I agree with. I think the sanctions and political pressure is... But you bring a good point. Not just us, America, but NATO did convince Ukraine to give up the nuclear arsenal with the promise that neither side would ever be protected from both sides.
Correct.
All right, with that, we have to go to break. Hold that thought, Doc. This is My Favorite Show, 1160 WVNJ. We'll be right back after these messages.
You're listening to My Favorite Show. Join the conversation by calling 800-962-1160. Stay tuned for more of Dr. Call and Greg Riccardi. We'll be right back after these messages.
We've been documenting history and informing our friends and neighbors for decades, and we're still the first place people turn for news and information. We're reliable when other forms of communication aren't. We're there before, during, and after a crisis to keep New Jersey safe. And we don't hesitate to put ourselves in harm's way to bring critical information to our neighbors. And unlike other media outlets, we're free, local, and available to everyone. But providing a free service to everyone is just the beginning. Who are we? We're New Jersey's broadcasters. Hi, this is Paul Rotella, president of the New Jersey Broadcasters Association, and every day of the year, our member TV and radio stations are there, delivering the breaking news and emergency information you rely upon, providing the music and shows that you love most. New Jersey's broadcasters are a vital part of every community that we serve in the Garden State. Find out more at njba.com and wearebroadcasters.com. So keep listening, New Jersey. We're New Jersey's broadcasters, and we're always on the air when you need us. This message sponsored by the New Jersey Broadcasters Association and this station.
I started my adventure as an aerospace medical technician.
Flight medic in the Air Force Reserve.
Satellite system operator.
As a space systems operator.
And I'm a pilot for the Air Force Thunderbirds demonstration
We
team.
deliver the world's timeliest environmental intelligence data.
Flying to Afghanistan, bringing wounded warriors back to Germany.
We take care of injured personnel on a daily basis.
And then flying them from Germany back to the States.
As a member of the Thunderbirds, I get to be a part of a team that passes on the message of the United States Air Force Reserve to the U.S. and the world.
It's a very exciting career.
One of the greatest things about the Air Force Reserve is all the different opportunities. The training in the Air Force Reserve is second to none.
It gave me the opportunity to go to college.
The Air Force Reserve actually paid for my education, which allowed me to commission. That was definitely a bonus.
Probably the most exciting thing I've done is support humanitarian relief operations in places like Haiti.
The Reserve gave me the opportunity to learn something totally different from what I did.
Being able to travel.
I enjoy the getaways that I get, and I enjoy the camaraderie and fellowship I share with all my unit mates.
We're really close-knit, we're unique, and the Air Force Reserve gave me all those opportunities, and then even more.
Start your adventure in the Air Force Reserve.
All right, we're back with My Favorite Show. I'm Greg Riccardi, Dr. Richard Call, and Dr. Victor Katz here in the studio. So while we're on break, we actually got a text in from Cynthia asking, what is the top things you could do to avoid back pain? Are there things you could, I mean, let's say you either sit all day long, or what are some of the things that are common causes of it that are preventable?
Well, that's a great question. I mean, it actually a good question that we, in general, don't spend enough time teaching patients about preventive medicine.
Sure.
How do you prevent something from happening rather than wait until it happens and then we kind of try to treat it? I think that's the key to medicine in general.
Sure.
I think prevention is the key, and if we spend maybe like 5% of healthcare dollars on teaching people how to prevent disease, there will be a lot less doctor visits and so forth.
They say an ounce of prevention is worth a pound of cure.
That's
right?
exactly right.
Yeah.
So how do you prevent back problems? Believe it or not, you can prevent back problems. One of the ways, number one way, is to regularly exercise.
Okay.
Exercise will lead to, first of all, a weight reduction. Somebody who is thin has less back problems, because somebody who is obese has to carry all that weight around, which affects not only the back, it affects the knee joints, the hip joints, any weight-bearing joint, and leads to early breakdown, early deterioration, and early arthritis. And spine is one of the organ systems that would be affected by obesity, by some larger people with that carry around a lot of weight have much more back problems.
Sure.
So one way is to exercise and to lose weight. If you're going to do exercises, the key exercises, I think, are core strengthening. What I mean by core strengthening is abdominal strengthening and back muscles, erecti spinae strengthening. The stronger your core is, the more protective it is of your back. It's almost like wearing a back brace, but the back brace is your own muscles.
Right.
So it kind of, again, prevents injury to the...
It's like an internal brace.
Sure. Yeah.
Correct.
Right.
That's exactly right. Now, once somebody does develop some back issues, let's say they have a dark disc or some evidence of disc degeneration, I think one of the key things somebody can do is quit smoking. Believe it or not, nicotine is one of the drugs that basically constricts your blood vessels and decreases blood supply to your spine, to your connective tissue, to your discs, and so forth. And as a result, that leads to accelerated breakdown.
Sure.
So quitting smoking would be number 3. I would say, losing weight, exercise,
and quitting smoking. Wow, that's actually surprising. I mean,
it's actually very well documented in spine nutrition.
It makes sense, in terms of the restriction of the oxygen stuff.
Absolutely.
But you never would think,
Well, that's why we need studies for.
That's why we have My Favorite Show.
That's right. Anyway, so aside from that is use of what we call proper body mechanics. Proper body mechanics is the way you would lift stuff without injuring your back. Probably the worst thing you can do is lean forward. If you're going to lift something heavy, you should actually bend your knees,
Right.
maintain proper or straight back alignment, bring that object close to your core, and then lift it up with using your legs. You should never kind of do what most people do naturally, is like, let's say, take a suitcase out of a trunk, which is like lean forward and then twist,
Right.
which is the one of the most common mechanisms of injuring your back through everyday
How do
activities.
you do that otherwise? How do you get it back?
Well, you get closer, you bring it to you, and then again, you use it.
You ask somebody else to do it, actually, right?
Yeah, they can do that too.
Call your neighbor.
Dr. Katz, I'd like to ask you, what you've just said makes complete sense and are true words of wisdom. So how would you explain the fact that 80% of spine surgery done in the world happens in America, which occupies only 5% of the world's population?
I was not aware of that. But
So, what the question? 80% of what? The spine?
80% of spine surgery that's carried out on planet Earth
Right.
is performed within the borders of the United States, which occupies only 5% of the Earth's population.
Okay.
So,
Could it be just a way we have more hospitals and more of the ability to do so per capita? Or no?
that's what that's my guess is. I think spine surgery is such a technical field that I think most countries, third world countries, just physically can't do it because of lack of technology, because it's really takes a lot to bring somebody to the operating room and do spine surgery on them. I mean, you need first of all a proper table to begin with. You need which are sometimes very expensive. If you're gonna do a good job in spine surgery, and you're gonna maintain alignment, you probably should use a Jackson table, which is a special table that may cost $90,000 to $100,000 just for one table. I mean, if you're gonna really do a good job in decompressing somebody's neck, do like ACDF. You want to use
what's ACDF mean?
Anterior cervical decompression and fusion. You probably would want to use a microscope, like a Pantera microscope, which gives you 10 times magnification and allows you to fully decompress the cord with optimal vision.
Right, but that makes sense. But if you were to compare the United States to Western Europe, I'm sure there are fewer people walking around with cages in their necks in Western Europe than there are in America.
Well, this is my own personal opinion, is that Western Europe has a lot of socialized medicine. Meaning Britain is socialized, I think France is, Germany. So in these places, there is a certain amount of healthcare dollars you can spend, which is literally getting the decision whether or not somebody gets to have a fusion or a ACDF. Some of it is determined by their. First of all, there's probably a waiting list. I mean, if you want to have neck or back surgery in these countries, you go on the list. It may take up to 6 months to a year to even get to the OR. So by that, there's a deficit of both, specialists to do it, and also I think in the healthcare dollars that they can spend.
So which brings me actually on to, Greg, forgive me for this slightly controversial area, the issue of what's called the Affordable Healthcare Act, which which is now in place. So that some people say that's a form of central control of expenditure of healthcare dollars. Do you think that things are going to move, in the same direction as they have done or they currently exist in Europe?
Well, I think that bill, although well-intentioned, I think that the intent of the bill was to insure everybody basically. But you have to remember that there is a certain limited amount of money that you can spend on healthcare. So therefore, how it's spent would have to be it is a way of determining how you spend healthcare dollars and who gets what basically.
Right, and the fact that and Greg, you may or may not know this, but the United States spends 18% of its GDP on healthcare compared to the United Kingdom, where they spend 4%. So you're right; it's an issue of healthcare expenditure.
Right. So what I think this is a way of moving America towards some form of socialized medicine. which I'm not sure is the best policy for America, where we're used to having best of the best. And I think that will change in the future if we start limiting or curtailing what we spend on our own health. I mean, it's like this. If you want to drive a Mercedes or drive a Hyundai, I mean, Mercedes costs more. Hyundai costs less, but they can give it to a lot more people. So it's a decision, I think, that's made up by our government to basically sort of move us towards a form of socialized medicine. And having...
So the intention, I agree with you, the intention was definitely a pure intention to extend coverage. I think the complicating factor in it was the insurance companies, who really, in my opinion, control the healthcare sector in the U.S.
Correct. I think that at the same time as we are cutting back on reimbursements to physicians, and we are increasing our healthcare cost of each plan. Our plans that average American spends on to buy healthcare insurance actually went up, I think, about 20 to 30%.
Right, so
across
it's
the board.
the unaffordable healthcare plan.
Correct. It was misnamed, but I think that and the reason was that to cover people who are older with a lot more health issues, the plan was to have the younger people who don't have medical problems, who don't go to doctors, to kind of shift the cost towards them in order to cover everybody, basically, which I think in essence is not a good strategy, because it kind of takes the incentive of staying healthy or preventing medicine out of this whole equation. Like, for example, I'll give you an example. If you have the way that our automobile insurance system works, is that if you're a safe driver, if you don't get tickets, you don't get into accidents, you get a 30-40% discount on your premium.
Right.
As opposed to if you're a very high-risk driver, you're going to pay double, triple, because you're going to end up spending more money. The insurance company will have to pay out more to fix your car and so forth down the road. So in a way, you would reward the safer drivers, and you would punish the ones which are high risk. And
is there a way to do that in the health arena?
Well, it used to be that way. For example, if you were younger, thin, not smoker, you would get a significant discount on your policy. You would pay 30-40% less than somebody who is not. So in a way, now the way it is now is that the younger, healthy person who is a smoker, or who is not a smoker, pays about the same as an older, obese smoker, irrespective of these factors. So it kind of takes the incentive out of staying healthy, just if nothing more than to save on your insurance.
Sure. Okay. That means we are headed to a break. My name is Greg Riccardi. We're here with My Favorite Show. Dr. Call is my co-host. And here we are going to a commercial break. We remind you to call in with your questions, 800-962-1160, or text to 313131. Thanks. See you in a bit.
You're listening to My Favorite Show. Join the conversation by calling 800-962-1160. Stay tuned for more of Dr. Call and Greg Riccardi. We'll be right back after these messages.
Help prevent accidents by removing any accumulated ice and snow off of your vehicle before you hit the road this winter. In New Jersey, any motorist who fails to do so faces fines of up to $75 for each offense, regardless of whether the ice and snow is dislodged from the vehicle, and up to $1,000 if flying ice or snow causes property damage or injury to others. So please remember, ice and snow, remove it before you go. Because in New Jersey, it's the law. This message sponsored by the New Jersey Division of Highway Traffic Safety, the New Jersey Broadcasters Association, and this station.
Hi, I'm Dr. Bob Marshall, PhD, host of Healthline. This month, our DHA 200 is on special. This pristine microalgae source of docosahexaenoic acid, an essential fatty acid, delivers great brain, nerve, eye, and heart support. Buy 2 bottles, get the third one free. Call 800-370-3447.
Do you worry about how much someone else drinks? Do you feel that if the drinker cared about you, he or she would stop drinking to please you? Do you secretly try to smell the drinker's breath? Are you afraid to upset someone because it might set off a drinking bout? Do you have money problems because of someone else's drinking? Do you ever ride in a car with a driver who has been drinking? We know it's not easy dealing with a loved one who drinks too much, but there's help and hope. Al-Anon family groups are for anyone whose life has been affected by someone else's drinking. You'll meet others who share your feelings and your frustrations. Remember, before you can help a problem drinker, you need to help yourself first. For a meeting near you, call 1-888-4AL-ANON. That's 1-888-425-2666. Online, visit www.alanonfamilygroups.org. A message from Al-Anon Family Groups.
All right. Okay, we're back with My Favorite Show. I'm Greg Riccardi here with Dr. Victor Katz and, of course, my co-host, Dr. Richard Call. Okay, now we'd like to talk a little bit about the differences in the techniques that are available in terms of remedying someone's situation. So we've got minimally invasive spine surgery we're hearing a lot about. Why don't you give us, if you could, a kind of a chronology of where we were, where we are, and maybe where we're going to go, in terms of the ability to help someone.
Yes. Well, minimally invasive surgery is it's not for everybody. Let me start with saying this.
Mm-hmm.
There are certain indications for it. There are certain contraindications. When the indication is there, it is great. I mean, you can go in, do a half-an-hour procedure, and the patient can go home an hour later. I mean, mostly that's used for, you have a big extruded piece of disc in a canal pressing on a nerve. You can do a minimally invasive approach, do a laminotomy through a little tiny incision of maybe an inch
Mm-hmm.
long, and pluck out that piece, and the patient can go home in an hour.
Mm-hmm.
There are other situations where it's starting to how you say it? But like I said, somebody who needs a fusion, it's something that probably should be done in a hospital setting.
Mm-hmm. Now, for the people that are out there, what is a fusion?
Okay, so what is a fusion? The fusion is when the disc is so decompensated, there's not much disc material
Mm-hmm.
left, and that disc collapses down, so that you have compression of the nerves in the foramen, but it also can lead to instability, where
Mm-hmm.
that segment becomes unstable. So to treat that, you want to basically do two things. You want to decompress the neural elements, and sometimes you need to do that by putting something into the disc to kind of raise it up, so you can get rid of the stenosis, which is caused by collapse of the disc. And then you stabilize it by fusing it, by putting metal screws and rods, and also using their own bone to basically get it to heal or mend.
Mm-hmm.
And that way you accomplish two things. You're decompressing the nerves, and you're reestablishing stability in the spine.
Dr. Katz, could I just, there was a point you just brought up about the hospitals and surgery. And, there was an article I read a while ago about the difference in the infection rate between hospitals and outpatient settings. And they found hospitals to be, places where people were more inclined to develop what are referred to as nosocomial or hospital-acquired infections, right? To a significantly greater degree than an outpatient setting where a patient comes in and out the same day. So do you think that fact argues for the outpatient setting as opposed to the inpatient setting?
I personally do not, and I'll tell you why. See, when you talk about generalizations like hospitals versus outpatient surgical center facilities, I think it more has the infection rates has to do more with technique of each individual surgeons. If you look at same hospital, you look at maybe 3 different surgeons. One surgeon is going to have a 10% infection rate. The second surgeon is going to have a 5% infection rate, and a third surgeon is going to have 1% infection rate. So a lot of it has to do with technique of the actual surgery, number one. Number two, fast surgery is better than somebody who takes a long time to do surgery. I think another way to prevent infections is to dose the patient regularly at 3-hour intervals with appropriate antibiotics. But in my opinion, in my experience, the most significant way to prevent infections, especially in the longer cases, is to do pulse irrigation. What that is you take a special device that pulses the fluid, the saline into the wound.
Right.
It kind of does mechanical debridement. But if you add antibiotic to that solution,
so it's like a garden hose on the back.
It's a garden hose, but it's using pulse energy of the water to basically clean the wound, and you add antibiotic to that sterile solution. And using that technique in my hospital, or like my team that I work with, I actually work with a neurosurgeon. His name is Artyom Vayman. We have a pretty low infection rate over the last 5 to 6 years, and I think it has to do with all of these factors. It has to do with the fact that you try to make the surgery efficient, shorten our time. First of all, you wanna dose antibiotics before surgery and during surgery if it takes more than 3 hours, and also use this technique called pulse irrigation with antibiotic solution.
Because to go to the issue of infection. This was one of the factors that when they were drafting the what we call the unaffordable healthcare plan.
Tell us what you really feel, Doc.
That's right. They looked at that and they actually came to this conclusion that it was the management of these infections that raised the cost significantly of healthcare.
Well, that's a very interesting point you bring up. According to the Medicare standards now, if, God forbid, somebody does develop an infection and they need revision surgery, take the hardware out, to do washouts, all of this is not paid for. They assume it's so the hospital and the physician has to take basically a loss.
A haircut.
A haircut when treating this patient who has developed an infection, which I personally think is ridiculous. I mean, there's certain people who will develop infections because of other reasons. For example, diabetics have a higher risk of infection rates. People who are immunocompromised. So sometimes you can't avoid it. Even with the best technique, you're still going to get an infection, and it just puts the burden of treating that patient on the hospital and the physician. And what does that mean? Does that mean that we shouldn't be operating on people who are, that's what they're saying to us, is that we should not be operating. If somebody's diabetic, we should pre-select them and say, you know what, we're not going to operate on you because you have a high risk of infection, and we don't want to take that risk.
Right, so part of that whole thinking was this, we're going to pay for performance, right? So the thinking was, if you're a good surgeon and you have good outcomes overall, there's going to be an incentive built into that. But that's to me, it seems a very difficult thing to do in medicine, because it's quantifying all of the variables it's a big task.
It's extremely difficult. I think, again, the idea is a good idea. I think that outcomes is the whole goal why we do surgery or we do anything in medicine. I think ultimately every physician wants to help your patient. You want them to do well, and having a way to evaluate that, I think, is critical. But I think the physician himself should be his own worst critic when he looks at his own results, and when he decides which technique or which procedures that he's going to use to make sure that his outcomes are
favorable.
Favorable.
Yeah.
Ultimately, that's what I think. I think that's a great idea. But you're right, there's so many variables to consider that it's hard to quantify that.
Right, because they did the same thing in cardiac care, didn't they, about 10, 15 years ago, where they started to set up registries of outcomes, and they were able to a certain degree to quantify that and to be able to stratify that in terms of cardiac outcomes. And interestingly, today most cardiac care is carried out by interventional cardiologists and not cardiac surgeons. So they did it in cardiac care, but the back is a very different animal to the heart, right? It's much more complex in many ways.
Right, and going back to outcomes, one way that they wanted to look at this is going back to minimally invasive procedures. Let's say you have injections that you do epidural injection, and epidural injections work for, let's say, 3 to 4 months. But when you take the cost of, and then you have to repeat it. So when you calculate the cost of that procedure, you have to take into account the time interval at which it works. And if there was another procedure that cost, let's say, 10 times more, but lasted for 10 years, which one would you choose as a patient?
Right.
Would you want to do a more costly procedure like a fusion that you know are going to be okay for 10 years?
Yeah.
Or are you going to be repeating the injections every 3 to 4 months for the next 10 years, which would relieve the pain temporarily but cost less, but last for a shorter period of time? The same thing happened when we developed when X-Stop came into market.
And the X-Stop is a device, from my understanding, that was implanted in a minimally invasive fashion to again open up the spine to get rid of what you described earlier as stenosis.
Correct. It was an alternative to laminectomy, and with or without fusion. What it was a little bolt of titanium that you implanted, like you said, minimally invasively, to open up the spinous processes and indirectly decompress the canal. What we found is that over time, these devices failed after anywhere from 1 to 3 years, and they had to be revised. So for a short time, it was if you take into the cost of the device, the time it takes half an hour, they go home same day, but it only lasts for 2 years. So the question is, would you want to offer it? So again, this device, it would be useful in a patient who, let's say, cannot tolerate the standard procedure, but I certainly would not offer it now to every patient who has stenosis by saying it's minimally invasive and you go home in an hour.
Right.
All right. That music means we're about to wrap up. Dr. Victor Katz, why don't you give us, how does someone get in contact with you if they would like to?
Sure. I have 2 offices, one in Brooklyn, one in Queens. The telephone number is 718-659-5344. That's the Queens office. And the Brooklyn office is 718-336-2258. I also have a website. My website is victorkatzmd.com. You can visit me on the website. It has all the 3 locations and telephone numbers. Thank you.
Excellent. Well, thanks for coming in and sharing your expertise on all things back, spine, and related. Thanks to my co-host, Dr. Call.
You're welcome.
And we'll see you next time on My Favorite Show. Be sure to visit MyFavoriteShow.com to watch the video of this broadcast, and we'll see you next week.
You've been listening to My Favorite Show, where Dr. Richard Call and Greg Riccardi discuss the matters that matter most. My Favorite Show is taped live Monday nights at 7 p.m. To watch the video of this broadcast in the WVNJ studio, visit MyFavoriteShow.com.